Hi, this is Dr. Joannides, Chief Medical Director at Optimum Re, and this is the Optimum Academy, Rheumatoid Arthritis 101, video number 1. Rheumatoid arthritis is an inflammatory disease. So let's get started. So rheumatoid arthritis is an autoimmune disease that attacks the synovium or the lining of the joints, causing inflammation and pain. It typically targets the small joints of the hands and feet. It can also affect the knees or ankles in a bilateral fashion. However, there are downstream side problems, including cardiac, pulmonary, eyes, or other systems that may be the target of the inflammation that causes rheumatoid arthritis as well. Understanding the underlying concepts helps us pivot to a new underwriting perspective of rating the inflammation, not just the arthritis that's diagnosed when rheumatoid arthritis is found. So we are analyzing the risks of treatment with biologics and the possibility of reactivating dormant diseases with those new treatments as part of our understanding of rheumatoid arthritis and the treatments that can be utilized. A diagnosis of rheumatoid arthritis gets us to a section in the rating manual, but we need to understand the underlying risks involved. So we're still using the 2010 American College of Rheumatology diagnostic criteria for rheumatoid arthritis. So it's synovitis in at least one joint, the absence of an alternative diagnosis, which we'll talk about in a minute. And then we use a point scale, so at least 6 out of 10 possible points. Use the highest score in each of the domains that we're going to talk about, and here are the 4 domains. The number and size of the joints, so more points for more small joints involved, fewer points for fewer joints or just big joints involved. Then we're going to talk about the serology tests that we use, either a rheumatoid factor or anti-CCP. We'll talk about what that is, and whether you get more or less points for that. Also an elevated inflammatory marker like SED rate or CRP, which only contributes 1 point. And then whether the symptoms have been present for greater than 6 weeks, which would also contribute a point. And the reason for that is that eliminates other self-limited diseases like a viral disease that causes arthritis that would not last longer than 6 weeks. So the differential diagnosis of rheumatoid arthritis, the other diseases that you'd like to eliminate as possible causes: osteoarthritis, symmetric psoriatic arthritis, Lyme disease, polymyalgia rheumatica or gout, and then the viral arthropathies that I mentioned, which are probably more short-lived, like parvovirus, hepatitis B or C, which may be long-lasting and cause a viral arthropathy, chikungunya, which is present in larger number of places now, including the Caribbean, and then other rheumatic diseases. There was recently a CDC advisory for chikungunya in Paraguay and other regions of the world, so it's good to be up to date on where these viral arthropathies are more active. Then, rule out osteoarthritis. I've listed a number of characteristics of osteoarthritis, so you can exclude osteoarthritis when you're considering whether a person has rheumatoid arthritis or osteoarthritis, and I've listed those here for you. Mainly, you'll note that in osteoarthritis, that distal joint in the hands are affected, and those are called Heberden's nodes. And it's one of the features that distinguishes it from rheumatoid arthritis, which usually affects the joints that are proximal in the hand. So, what are the diagnostic tests we use? The erythrocyte sedimentation rate, or ESR, CRP, or C-reactive protein, rheumatoid factor, anticyclic citrullonated peptide, or anti-CCP, also called ACPA, anti-nuclear antibody, ANA, complete blood count, Vectra DA, which is an investigational tool, very expensive, I haven't seen one, and then x-rays of the hands, wrist, feet to look for joint erosions. So the ESR, that's an easy to do test. So elevation varies with the severity of the inflammatory process. It can be as low as 20 to 30 millimeters per hour with mild joint activity, but it could be much higher in the 50 to 80 range in severe disease. And then effective treatment with medication can bring down the ESR. So you can use it as a barometer of what the status of the disease is with treatment. The C-reactive protein, it's a ring-shaped pentagon found in the blood plasma when inflammation is present. It's called an acute phase reactant because when inflammation is present, it's produced by the liver. It was first identified in the cell wall of the pneumococcus bacteria. That's why it's C polysaccharide reactive protein. That's where we get the CRP from. And we even use CRP in a highly sensitive fashion when we're looking at possible cardiac disease. But rheumatoid factor, it's positive in 70 to 80% of patients with diagnosed rheumatoid arthritis, but it's not specific. So less than a third of patients with a positive rheumatoid factor actually have rheumatoid arthritis. They may have other connective tissue diseases, or rheumatoid factor may be positive in healthy people. And people that are age greater than 65 may have a positive rheumatoid factor test, but don't have rheumatoid arthritis. The titer of the rheumatoid factor increases with the severity of rheumatoid arthritis. So that's one thing to keep in mind. But here are other conditions that can show a positive rheumatoid factor: lupus, Sjogren's syndrome, chronic liver disease, sarcoidosis, pulmonary fibrosis, hepatitis, all kinds of things. But then also, if you'll notice, the last bullets are healthy individuals greater than 65 years old, post-vaccination, post-transfusion. So there's a lot of reasons to have a positive rheumatoid factor that don't indicate the person actually has rheumatoid arthritis. So what's this citrullinated peptide business that I mentioned? So this is anti-cyclic citrullinated peptide, or anti-CCP, or anti-citrullinated protein antibodies, ACPA. If you see the word citrullinated in lab tests and in APS, this is probably what they're talking about. It's produced by the B lymphocytes, and it is an indicator for inflammation. It's present in 70 to 80% of patients with rheumatoid arthritis. It can also be found in other rheumatic diseases. The sensitivity is about equal to rheumatoid factor, but the specificity is greater than rheumatoid factor. It's not as useful as predicting the future severity or progression. Like as we indicated with rheumatoid factor, a higher level indicates increased severity. That's not the case with anti-CCP. And I've put the values as negative to strongly positive below. So sometimes a person has seronegative rheumatoid arthritis. In other words, there's no rheumatoid factor or anti-CCP detected, especially early in the course of the disease, but they have the typical symmetrical small joint activity, synovitis, and the severity is thought to be less than typical seropositive rheumatoid arthritis that do have the positive tests. But if it looks like rheumatoid arthritis and it sounds like rheumatoid arthritis and it walks like rheumatoid arthritis, just like a duck, it's probably rheumatoid arthritis. So treatment with a DMARD should not be delayed. So what are the hematologic findings in rheumatoid arthritis? For the CBC, you can get a normochromic normocytic anemia, which is called anemia of chronic disease due to ineffective erythropoiesis. It could have thrombocytosis with an increased platelet count, the white blood count. You may have a mild increase or you may have a decrease. And if you do have a decrease, it can be called Feltes syndrome. And then, of course, the ESR is elevated as an indicator of inflammation. So inflammation is the risk factor. Unabated inflammation is the bad actor in rheumatoid arthritis and other autoimmune diseases. Inflammatory factors don't just prey on the joints. They attack all the vital body systems like the cardiovascular system as well. So there's an inherent risk for cardiovascular inflammation and disease as a target of this inflammation. So key treatments that are directed at the arthritis also may help with the inflammation in the entire body. Inappropriate inflammation is the real risk factor. So we have cytokines in our body. So what are cytokines? We're going to talk about that in a minute. But in a healthy person, your body naturally manages the amount of inflammatory response when you have some sort of agent that's causing a problem. So in disease, in a healthy person, you have the inflammatory response to respond to maybe you have a cut or an injury. Your body responds with cytokines in an appropriate inflammatory response. But in disease, what happens is you end up with an overproduction of cytokines and an overproduction of a cellular response, which leads to continued inflammation and painful symptoms. And that's what happens in rheumatoid arthritis. And the inflammation is not just limited to the joints, but may affect the heart, arteries, or other systems. So here's a drawing which I did, to show on the left what a normal articular cartilage in the joint would look like. And then to the right, in rheumatoid arthritis, you have synovitis, cartilage destruction, and you have what I call a cytokine soup that's produced by T and B cells and macrophages to create this inflammatory response that attacks the cartilage and can actually have erosions in the joint. So what is a cytokine? I always had trouble wrapping my head around what a cytokine was. It's a broad and loose category of peptides important in cell signaling and immunomodulating agents that are important in good health. Comes from the Greek word cyto for cell and kine for movement, so the movement of cells. And in disease, what happens is there's an overproduction of these cytokines produced by cells like T and B lymphocytes, macrophages, and mast cells. And you get tumor necrosis factor alpha, interleukins, and lymphokines, and interferon gamma that all contribute to this cytokine soup and cause inflammation. So I have a picture of minestrone up at the top right. So this immune soup of all sorts of ingredients we have to keep us healthy and respond to injuries or things of that sort. But when it's overproduced, that's when the problem arises. So when the body overproduces any one or more of the ingredients in the soup, bad things happen and you get bad soup, just like if it was too salty or too much pepper. So there's a problem in the body with increased inflammation that you really don't want. So not all rheumatoid arthritis cases have the same degree of bad ingredients. Some may have more of one and less of another. So that's why different drugs may be tried or different DMARDs, because there are different causes of the inflammation in rheumatoid arthritis. And it's kind of like a rebellion in the body. So this is a picture of college when I went to college, and we had every spring we would have a rebellion. So rheumatoid arthritis is kind of like rebellion in the spring that we would have at college. Now you have a few activist lymphocytes and macrophages that rebel against the status quo and go rogue. This causes an uprising and enables a toxic environment in the joints. A revolutionary destructive movement ensues to drive chronic inflammation and disrupt the peace and tranquility, just like our spring uprisings in college. Other bystander organ systems like cardiac or pulmonary can become collateral damage, raising the mortality risk. And then to rectify the situation, anti-insurgent DMARDs or biologics can assist the body's defenses to put down the various rebellion. In our case, it was usually the North Carolina National Guard that would come in campus, spray pepper gas, which is that cloud you see in the picture, put down the rebellion, and peace can be restored. But I kind of miss the good old days of the spring rebellions in college. So I'm happy to see, though, that we have new medicines to treat rheumatoid arthritis and put down rebellions in our joints. So ratings for inflammatory response in the cardiovascular or other systems, people don't die of arthritis in their joints. They may get disability, but it's really the downstream inflammatory process that affects the heart, blood vessels, and lungs that we're actually rating. And all that high level of inflammation would add increased mortality risk. And in rheumatoid arthritis, there's approximately a 1.5-fold risk of atherosclerotic cardiovascular disease compared with the general population. So, in rheumatoid arthritis, critical thinking is always important. And as Yogi said, 90% of underwriting is 50% mental. So that completes video 1 on rheumatoid arthritis. Stay tuned for video 2.